cystitis, which is inflammation of the gallbladder. Cholelithiasis is going to be stones in the gallbladder. The major thing you see it happening in women who are fair, fat, and 40, that's what you call the gallbladder patient typical. Caucasian women, fair skin, who are chip, usually are the people that happens. But I will tell you, gallbladder disease can happen in teenagers, 13-year-olds, people who lose a lot of weight rapidly. You know, if you got somebody that goes on one of those diets where you just see them today and the next day they go, you know, where they go, those are people that do that kind of thing. And they're like, what? That doesn't happen, yeah. Those people that do liquid stuff, because you lose a lot of weight quick, those are people that usually have it. All right, so that is our GI, GU, and we have fluid and electrolytes that are going with this particular chapter. I mean, two particular texts. For your patients who are bariatric patients, it's a whole specialty, subspecialty. Now, when you talk about patients who have nutrition and malnutrition issues, and a lot of people think just because a person is obese that they are well nourished or overnourished, but you can actually have an obese patient who is malnourished. So just the size of the patient doesn't tell you that. You have to look at some other things that go along with that. For lab values, you look at your serum protein. You look at your albumin levels, and you look at prealbumin levels. Prealbumin is actually the most sensitive test to look at nutrition for a patient. It's the most expensive of the three tests, of course. You'll get this one, you'll get these two on a regular chemistry 24 panel, or when you do a full panel on a patient, because a chemistry 8 just gives you certain things. But if you do a full panel, you're going to get albumin and protein on there. This one you have to order as a separate test, but it's very expensive. But it's the truest and most accurate indicator of nutritional status because its half-life is 24 hours. So that means that somebody can come in, you test them, so when you do it every 24 hours, you know where their nutritional status is. So you're looking at how much they eat, yes. You're looking at weight, yes. But if I want to get a true picture of where their nutritional status is, that's the test that's most sensitive to it. Okay. So when you're looking at nutritional status of patients, you're looking at several things. It's an assessment piece that goes along with that. Going back to your hematology stuff, when we talk about patients who have anemia, same kind of thing you're looking at to look at nutritional status. So you're looking at skin, you're looking at oral mucosa, because it gives you an idea about what's happening with that patient. You're looking at, because you're seeing if there's pallor, if the mucosa is moist, if it's smooth, if there's lesions, all that kind of stuff that goes along there. Okay. You're looking at skin turgor to see whether or not this patient is dehydrated, if they have good bounce back of skin. You're also looking at muscle mass to see if it's well distributed, if they have firm muscles, or if there's muscle wasting that you sometimes see with patients who are malnourished, or that you sometimes just see with pathology. A person who has COPD that's really bad, all they're working on is breathing. You know, that's what their work of the body is to do, is to try to breathe. So for them to have big muscles is rare. What they tend to have is muscle wasting because all they're doing is actually trying to do the work of breathing, kind of thing. So you're looking at symmetry of muscle distribution, if there's muscle wasting or weakness, those kind of things. You're also looking at how they're up and able about to do things. Are they able to move, get around on their own, or is that something that they have a problem with? You're looking at all those things in the context of what's happening with your patient. Then we also look at their weight. Where are they between height and weight? So you're looking at their body mass index to see whether or not they're considered, you know, obese, malnourished, morbidly obese, whatever it is for the patient. But still, even if you see a big person, you look at these numbers to see where they are. Because yeah, they're eating calories, but are they truly nourishing the body to get what they need? Those are things that we kind of look for in that patient. So when a patient is malnourished, of course, you have to increase their caloric intake or increase their ability to absorb and use the nutrients that you give them. Because now if they have pathology, that's hard to do. Think about if you got somebody going on with the GI tract. We talked about the inflammatory bowel diseases. That's a person who could lose weight quickly because they're having diarrhea, they're having nausea and vomiting. All those things are going to be fluid losses that this person can have. And then because you're doing that, you put the body in a hypermetabolic state. So those are the kind of things you're looking for and seeing. But if you got something going on with the bowel, it's hard for you to get a resolution of something that's happening in your GI tract until you get that process under control, for you to be able to actually eat and absorb nutrients. That's the problem when we talk about GI stuff that's going on with your patient. So you have to get whatever their underlying thing is under control. Then you're going to, if you can, feed them orally. If you can't, then you have to look at doing TPN. If you have to go past the area where the person has a problem, that's when you get Dopphoff tubes, that kind of thing, you're going to be doing feeding for the patient. Usually there's going to be a nutritional support team consult, meaning that somebody's going to come and see how many calories the person needs, figure out how much that is for the patient, and then order the prescribed amount of things to be given, whether it be from TPN, tube feeding, oral feedings, or all of those above. But they figure out how many calories this patient needs to actually maintain health and get better. Okay, so those are the things they do first. That diagnosis of cancer is one of those that always puts you behind. Anytime a person has a diagnosis of cancer, puts them at risk for having DVT. We talked about that when we were talking about vascular stuff. But the other thing it does is, if you look at nutritional status and healing, it's going to be a problem for a patient who has cancer. Some doctors will actually bring a patient to the hospital, do all their workup kind of thing, put in a doc office, send the patient home and do tube feeding. What they want to do is increase your nutritional status so that once I cut you, you heal better. If you got that little emaciated patient there, they don't do as well. So those are things that sometimes you'll see a doctor do even before they do surgery. So they find out how many calories this person needs, divide it up into what they do. You try to get things that are nutrient dense, meaning that out of the least amount of food, especially when somebody can't tolerate food, the better the calories or more dense the calories and the least amount of food. So sometimes you'll see people do burn shakes, even though they don't have burns. Burn shakes are usually things that have high calorie, so they're high calorie, high protein for the patient, and they can give it so that one cup of a burn shake is like, drinking 3 milkshakes or 3 Ensures, because you're talking about the calorie, nutrient dense kind of stuff that patients are doing. So you can see all those variations done. You may also see people get double strength tube feeding, which tends to be hyperosmolar. So the one thing you gotta always remember when you have people on double strength feeding is that you always gotta give fluid. So sometimes you'll see free water given during the time they're getting their tube feedings. And sometimes that people don't realize, you actually make the patient more dehydrated if you don't give them water. When you're talking about double strength feeding, they end up in the hospital. You go, why is this person, we're giving them tube feeding? It's not just that. If you give them those double strength feedings and don't give water, problematic. Then we have a whole new episode, or a whole new subset of medicine called bariatric nursing. Because you can actually get a certification in taking care of bariatric patients now. And in most of your hospitals, every time a hospital floor gets remodeled, they're putting in toilets, everything to treat bariatric patients. Mainly because when you have really heavy patients, they destroy things in the bathroom. I know that sounds crazy, but if you have to get them off the floor, you'll know what I'm talking about. All right? If you ever had a patient, a bariatric patient code is very hard. You can't do anything but pull them to the floor and do the code on the floor. Because you got to have a whole lot of people to get a bariatric patient off the floor. So you just pull them down on the floor. That becomes your backboard, and you just start compressions on the patient. I had to do it a couple of times in my life. All right? There's nothing you can do. And it's worse if they get stuck someplace like in a bathroom. I'm trying to figure out how you're going to open the door. Because some bathroom doors only open in one direction. You just want to kill yourself. And wish you were off. You feel sorry for the patient, but you just want like, I don't know, how the heck we going to do this? Kind of thing. The door only goes this way, I'm this big, I can't fit in there, oh Jesus. Kind of thing. Because basically what you have to do is put a sheet on the floor or a blanket on the floor, put them on the floor, and then pull them out the door. You can't pick anybody up. But you're trying to do all of that in this little space with all of this. That's wrong, right? That's just crazy. So when you see people nowadays, it's a whole subset of treatment or that we're doing with patients. Part of it is that, of course, you have to be sensitive to that. People are feeling, people who are big, we know we are. But there are some people that's all they want to talk about is this big, nasty patient. That's the part that makes me crazy. But for the grace of God, even if you were a little skinny person, somebody could say the same thing about you, a little nasty patient. So that's the way you have to do that. Okay? I'm just saying. You got to think about those things. But there are some people that treat the patients that way. That's what I have a problem with. But it is a whole specialty. And then what they want to talk about, of course, is focusing on what can we do to change behavior. So modification ends up being changes in lifestyle that will hopefully get this person to a more manageable weight. I've never had, like some of the people that you see on TV. I think that probably the biggest patient I ever had was probably 540 pounds. But you see patients 800, 600, all this kind of stuff. It boggles the mind to think about how they even get up and do anything. So they already feel that when they're in the hospital, and they know that. But what we have to do is try to focus on the positive things that they are doing. And it's the same thing with anybody. 10% of your body weight, I can see. So even at 600 pounds, 10% is only 60. So a patient can see that, even though they need to lose 400. I can see 60 better than I can see 400. So that's how you're going to be working with the patients to do that. Now, of course, nowadays what we end up doing is seeing patients who actually have gastric bypass surgeries of several types, or sleeves, or balloons, or whatever it is that person has done. And we do see a rapid weight loss in the patient. Now, of course, there is supposed to be screening that goes along with that, because psychological counseling and that kind of stuff needs to happen before the patient has surgery, because it changes everything. It changes the dynamics in the family, how people do things, and people don't realize that. And sometimes the patient nor the family is ready for the change that happens. So sometimes you have people going crazy, they get skinny and just go buck wild kind of thing. Or you have family members that resent that now this person doesn't need them anymore. So you have a lot of different things that are going on when you see that with patients. The major thing, of course, is that you have to be sensitive to that. Provide patients with information about options. And one of the things that was approved, I think either last year or right at the end of the year before, end of 2015, is that how it used to be for bariatric surgery, unless you had medical conditions, it was considered cosmetic, so you had to pay for it yourself. American Diabetes Association came out with a statement that bariatric surgery is considered curative for diabetes. So that meant a lot of patients who had diabetes could now get their surgery done and paid for, which is a good thing. But you still have to modify. You see a lot of people go off medications, but just know they do the surgery and modify it, but you have people that will eat themselves back up to weights that are crazy. It's only a momentary fix unless the person has a change in behavior. It's going to do what the person has to do. And when they do bariatric surgery, use an outpatient procedure. Patient comes in, has it done. Outpatient in the fact that it's observational. They come get their surgery in the morning, they stay overnight. The next day they're going to test them and have them drink a little bit of water. They go down to x-ray to make sure there's not leaking at the anastomosis site where they actually did the surgery. Then they're going to be on a liquid diet. The vast majority of people stay in the hospital maybe 2 days. And then they go home and start on their diet. They still drink liquids for that first period of time. And it's going to be a progression. Just water, then they're going to start full liquids. Clear liquids, full liquids, and then they're going to progress their diet. The major thing they do when a patient goes home after bariatric surgery is that they're going to start eating off a saucer instead of a real plate. You have to teach them that that's what you have to eat off of, because now your stomach size is very small, and that you have to separate your food and your water so that they never sit and eat. You know how we're so accustomed to having something to drink when you eat? They end up with dumping syndrome if you do that. Push your stuff along, because now your stomach is smaller. Once you eat something, food goes through it quick, because you don't have much surface area there anymore. You're going from something that was like this to now tiny. So when you put water in it, your body registers, Sharon, you ate food. You have an intact pancreas, it's going to release insulin to cover that food, but you put water in it, you just moved it on down, where your body doesn't have time to metabolize it. So you have people that have dumping syndrome. And just think about dumping syndrome as I have sugar that I moved along with water, and now all I have is just water. So they have signs and symptoms of hypoglycemia. So that's why they're diaphoretic, and that's why they call it dumping syndrome. Just dump it out of the stomach. Not available to you to use. And that's something that gets better over time, but you got to get rid of that water with your food. You always do water like 2 hours after you eat. And one of the other things that you can do is once you finish eating, the only time in life somebody will tell you to lay down after you eat, especially black people. Your mama says you don't ever go lay down after you eat, right? I don't know if Caucasian people say, I'm just saying because this is my experience. But they never let you lay down after you eat. You got to get up and go do something. I don't care how tired, even on Thanksgiving, get up, don't be laying down, kind of thing. That was what we did. But with this particular thing, if you lay, especially on the right side, which is the outlet for your stomach, it's going to keep the food in there a little bit longer, so you have less dumping syndrome symptoms in your patient. But that is something that gets better once the patient learns how they have to do their meal. So it's pretty much they go on the Gray's diet, 6 small meals a day. And that's what everybody says, the paleo and all those kind of things where people actually lose weight, those are what say that works. Start eating off a saucer and eat 6 small meals a day instead of eating 3 big meals a day or 2 a day. And part of it is that we never eat breakfast. That's part of it. Every person, if you can talk to a personal trainer, that's what they'll always say. The reason you're not losing weight is because you don't eat breakfast in the morning. Because you make yourself crazy. Your body stores, it's going to use and store food because you're not giving it what it needs. So you actually make fat by not eating breakfast. Like, that's the stupidest thing I've heard. That's what you think, but when it's really the truth. Your body says, you're starving me, so I need to save stuff for the next time. And then when you eat later, you eat like a fool. So then you actually put more fat on top of there, but that's what your body is saying in the morning. If you don't feed me in the morning, it's going to store everything that you put into it, so the next time you don't feed me, I have something available to it. So you actually lose weight by eating more. If you ever talk to anybody about dieting, or you go to professional dieting type companies, that's what they'll tell you. The reason you're not losing weight is because you don't eat. And you're sitting there, everything in life tells us that's the opposite of what we should be doing. But that's what really works. And then you get a personal trainer just to make them work like a fool. And try to kill you. That's my brother. Okay.
This exam.
So what we